Medical debt comes about when patients receive care services of whatever form and they're unable to pay for them. Even in the presence of medical insurance, medical debt could be unbearable. Patients are forced to seek alternative sources of funds in the event that they lack personal savings or sufficient credit, are ineligible for charity care, or are not covered by any form of healthcare insurance. Unlike every other debt you could possibly think of, rarely do people plan for medical debt. 2/3 of medical debt is incurred from a one-time or short-term medical expense associated with an acute or dire medical need. The unique nature of medical debt is also associated with the fact that people rarely have the opportunity to shop around for medical services, with the related choices being limited by price opacity, restrictive medical networks created by providers and/or insurers, constraints associated with provider availability, and emergency needs being the most important of them all. As of 2016, about 25% of Americans experienced difficulties paying medical bills or knew someone who was experiencing difficulties. 79 million Americans struggle to clear their medical debt or are facing challenges paying off their debt. 43 million Americans hold a total of $81 billion in medical debt. The high cost of care does not only burden families and individuals seeking care financially, it also prevents them from accessing care, with up to 25% of adults foregoing necessary care owing to related costs. According to the Consumer Financial Protection Bureau, as of June 2021, there was $88 billion in medical debt on consumers' credit records, with the number being more likely to be higher since not all medical debts in collection are available to consumer protection agencies. This number is not exactly defined as it depends on the source you look at, ranging between $81 billion to $140 billion. Similarly, anywhere between 18 and 35% of Americans have some form of medical debt. Most customers' medical debt is under $500, even though people have debts with multiple collection agencies. As of 2021, 58% of all debt in third-party collection agencies was medical-related, which is followed by telecommunication debt at 15%. Four major healthcare stakeholders play important roles in the whole medical care complexity, especially medical debt. These stakeholders are patients, healthcare providers, healthcare systems, and insurance companies. Patients are at the center of healthcare systems, especially with modern approaches to cost-effective holistic care. Patient-centered care, which is very important as it pertains to both short-term and long-term treatment, entails providing patients with all the necessary information for them to make informed decisions relating to the course of treatment. In short, patients are no longer perceived as third parties in their treatment processes. The patient is central in the whole healthcare network comprising of them, healthcare provider, insurer, and their employer, as in the case of employer-provided insurance. Asset-limited, income-constrained, and employed, popularly known as ALICE, patients are commonly referred to as functionally uninsured as they are testament to the relationship between debt and population health. The whole medical billing and resultant debt settling processes begin with the patient seeking care. Rarely do patients decide when they need to seek care, especially low-income earners. As such, very few people determine when and how they will come into contact with healthcare systems and all the other stakeholders. This phenomenon raises the complexity of medical debt, especially considering the fact that patients are required to navigate healthcare systems with little to no assistance from the other stakeholders. Complex healthcare systems are not only tedious to patients, they also become more expensive, which is more money for all the stakeholders but the patient. The complexity of healthcare systems culminates in medical debt, with patients who have medical debt owing other types of debt, including mortgages, auto loans, student loans, and general credit card debt. 47% of patients say they're unable to pay medical debt, with 41% citing that other bills are more of a priority than medical bills. It therefore follows that in instances where non-payment leads to the loss of a necessity such as a home, medical bills are often shelved since healthcare cannot be repossessed. Healthcare providers and the accompanying support staff are responsible for providing care to patients, and as such, they're also important stakeholders in the whole medical debt thing. Clinicians, being part of healthcare facilities or systems at large, are the first line of interaction between patients and healthcare systems. Physicians attend to patients, with attending in this case involving anything from taking patient information, conducting all the necessary tests, providing all the required prescription information, and most importantly in the context of this video, discussing treatment costs. Healthcare providers' ability to discuss treatment costs is heavily dependent on the nature or context of patient-provider interaction, which could be regular, preventive, or emergency care. The whole complexity of patient-provider interaction is further compounded by tort risk that encourages physicians to advocate for proactive medical services and with that, avoid the difficulty of discussing non-care. Inexperienced patients, if that's even a thing, or uninformed ones, may be unaware of the fact that they can challenge treatment interventions based on their cost-effectiveness, that is, the relative cost of treatment compared to projected outcomes. Providers in primary or preventative care settings are always pressured into attending to as many patients as possible, which limits the patient-provider interaction time and subsequent satisfaction. Staffing shortages also reduces the amount of time a patient has with medical professionals to have related conversations. Rarely are conversations surrounding the cost of care had with the patient unless the underlying treatment interventions are extremely expensive, of course expensive in this case being relative. As a result, patients are unable to select cost-effective treatment plans that are good for both their health and their pocket. The problem is worsened by the fact that emergency and inpatient care in about 50% of hospitals are extremely expensive for the average patient. Healthcare provider supporting staff are responsible for collecting patients' insurance information, determining their eligibility for financial assistance, and submitting billing information to insurance agencies and other third-party payers. The Federal Emergency Medical Treatment and Labor Act, EMTALA, which requires anyone coming to an emergency department to be stabilized and treated, regardless of their insurance status or ability to pay, prevents the discussion of healthcare costs until a patient has been treated. The Act makes sense in the context of the state at which patients arrive at healthcare facilities and their state of mind at the time. Healthcare or hospital systems are termed commonly used in referring to interconnected healthcare facilities that facilitate stakeholder interaction. Small providers in relatively small facilities do not have the resources necessary to influence entire systems, but they do interact with patients anyway. Healthcare and hospital systems set the price for all services provided to patients. This cost is based on the overall overhead costs required to sustain the system, combined with reimbursement from insurance, Medicaid, and Medicare. Once a patient's bill has been coded, the billing department prepares the bill and it is sent to the insurer. After the insurer determines the patient's liability, the patient receives their bill for out-of-pocket expenses or copay. The patient is provided with an opportunity to question or dispute the charge entirely, but very few patients are actually aware of the underlying processes. The Consumer Financial Protection Bureau has constantly pushed for delayed reporting of medical debt to credit agencies since it takes up to 6 months or more to correct billing errors, especially navigating the disputes between insurers and healthcare providers. Patients eligible for charity care are unaware of their eligibility unless they are informed by their provider. Hospitals and healthcare providers have largely been criticized over the recent past for constantly making charity care inaccessible to patients, Despite receiving tax exemptions and federal funding in millions of dollars, with some of the highlighted facilities being Atrium Health in North Carolina and Providence Health in Washington state. Questions have started being asked about the deficiency of charity care provided to local communities compared to the incentives provided to the facilities in question, especially tax breaks and federal grants. As of 2022, North Carolina was formulating a bill that would codify rules governing the provision of charity care, as well as limit the ability of healthcare institutions to charge unreasonable interests. The fact that patients' knowledge of eligibility to charity care is based on the information provided by the healthcare provider implies that a lot of patients still receive medical bills. Even when patients are informed that they're eligible for charity care, the necessary paperwork is cumbersome and overwhelming. The paperwork requires documents that could be difficult for patients to provide, thereby discouraging application even with all the relevant information. Insurance companies pay for healthcare services and use their influence to negotiate with providers for better treatment rates. The relationship between insurers and healthcare providers is largely symbiotic. On the one hand, healthcare facilities and providers are incentivized to work with insurers because a consideration of their services results in an in-network relationship that opens up a new pool of paying and committed patients. The whole paying and commitment aspect is of course through their insurance. On the other hand, insurers are incentivized to work with healthcare facilities in providing patients with a wide selection of affordable healthcare providers. Health insurance plans, while they do vary in terms of complexity and readability, are generally divided into two. The first type of healthcare insurance plan involves paying higher monthly premiums in exchange for low out-of-pocket expenses. The second type of plan encompasses paying low monthly premiums for high deductibles. Both plans have co-pays for certain healthcare services, as well as out-of-pocket expenses counted against deductibles. Insurance companies access lower rates for certain healthcare services and pay a certain part of the resultant bill, that is until the patient's deductible is met. The only requirement for the patient is to restrict their pursuit of healthcare to within their network. Price negotiation is largely dependent on the market, with the pool of in-network providers constantly changing without the patient's knowledge. In some instances, even medical staff are unaware of what a patient's insurance covers despite having information on medical code. Patients are often caught between insurers and healthcare providers when there's a duel over allowable costs for offered services. The disagreements between providers and insurers not only affects the overall cost of care, but also derails patients' treatment processes, thereby raising the risk of poor health outcomes. The limited time to find new in-network providers for the patient implies that the easiest route is to avoid care entirely, which of course, has its own set of consequences. The whole idea of forgiving medical debt, while it might sound appealing and nice, it would not exactly be sustainable for healthcare systems. Hospitals have salaried staff, require equipment that is both purchased and maintained, need to stock medication and the relevant supplies, and treatment processes could be lengthy. Rising healthcare costs are not only stressing to patients, but while it might sound ridiculous, hospitals are also under pressure. Some sources suggest that from 2019 to 2020, health spending in the U.S. increased by 9.7% to $4.1 trillion or $12,530 per capita. Of that total, $389 billion was paid out of pocket by patients. Staffing shortages, the exponential rise in prescription medication, and the constant inflation of medical supplies by Big Pharma has worsened the challenges faced by hospitals. A combination of these factors has significantly raised the amount of losses incurred by healthcare facilities, with some sources suggesting that a third of hospitals are operating on losses. The challenges faced by healthcare facilities are particularly worse in low-income neighborhoods where hospitals may not only be the biggest healthcare provider, but also the biggest employer. Before hospitals close as a result of operating on losses for an unsustainable period of time, They first embark on strategies to cut costs and raise the probability of survival. These cost-cutting strategies range from terminating the provision of essential services, to reducing the number of professionals in a facility, to outsourcing essential services. All the strategies used by hospitals to cut down costs are not good for the facilities, and they're definitely not good for patients. Without sounding like corporate washing healthcare institutions, or raising questions over who the sponsor of this video might be, we ain't there yet by the way, but we will get there someday. Healthcare facilities aren't exactly headed or run by saints. Actually, depending on who you ask, healthcare facilities have a special seat in the place with eternal fire right next to big pharma and people who eat pizza using a knife and spoon. Common sense, which is also backed by research, suggests that healthcare facilities charge more for procedures and medication than what it costs them because, surprise surprise, they're part of the system. Charging more than it costs hospitals for treatment interventions helps cover expenses and future needs. Extra costs are also used to leverage with insurers, probably by providing sophisticated services which then translates to having more patients. There's also the fact that the size of a hospital determines its negotiating power in the relevant circles. Rarely do insurers pay the full amount of treatment for insured patients, with the rates being charged in totality to the uninsured. Median markups are 5 times what the procedure costs in non-profit federally funded facilities, while they're 12 times what the procedure costs in the case of for-profit healthcare organizations. The incentive for higher markups in the case of hospitals is also associated with the fact that each additional dollar of list price results in an extra 15 to 20 cents in revenue for the hospital. At the end of the day, the rise in costs don't begin with the patient, but they definitely end with the patient in terms of medical debt. Problems with billing or medical debt collection process result in even bigger problems for the patient. It is obvious that patients only know what they know, and with regards to the treatment process, especially billing, it's not much. However, healthcare systems assume the patient has enough knowledge, experience, and most importantly, time, to ensure that they are fully aware that they can afford the care they seek and that they have the correct bill after receiving care. The reality about these assumptions, nothing could be further from the truth. While patients might be a bit knowledgeable, they don't know enough to dispute the application of medical codes or ascertain that their insurance was billed appropriately. Patients are not exactly knowledgeable about their eligibility for charity care or the necessary paperwork to access care. The American healthcare system also assumes that patients could advocate for themselves in the event of billing issues or provide a miscommunication. Some studies suggest that patients who are aware of their eligibility in the case of financial assistance are 4 times more likely to explore the related programs compared to those who don't know. Those with the knowledge of eligibility for financial assistance are also 8 times more likely to secure some form of financial assistance compared to those who don't. Once a bill goes into collections, patients feel intimidated to even try negotiate a settlement or payment. Patients who are a bit well off just pay up the bill and get it over with. However, 35% of Americans cannot afford $400 on an emergency basis, a phenomenon that translates into debt in the event that the emergency shows up. The most common problems surrounding medical billing include improper billing, minimal patient involvement, and insurance coverage gaps. Collection agencies are tasked with the responsibility of ascertaining that the patient is billed properly, a task that could prove to be extremely difficult. Minimal enforcement has allowed rogue actors in healthcare systems pursue accounts that should be forgiven or corrected. A lot of Americans signed up for high-deductible plans under the Affordable Care Act, which resulted in acquiring expensive plans characterized by very large out-of-pocket expenses. In the case of high-deductible plans, a lot of patients are not aware of the benefits they should be getting from their insurers to avoid medical debt. Patients are also unaware of the prices offered by different providers for the same services, the medical coding practices for various bills, how to challenge medical bills, and how to go about accessing charity care. Medicare and Medicaid do not reimburse healthcare facilities for the full value of their services, thereby incentivizing the need to shift the balance of operational costs to include private insurance. Patients' knowledge of their healthcare plan, especially the entirety of their treatment network, and comprehension of their medical bills raises the chances of evading medical debt. This knowledge is particularly useful for uninsured patients because they're most affected by communication flaws in charity care,